Well, thank you everyone for inviting me to present at a seminar. It's quite special to be able to show you some of the work that myself and colleagues have been working on. And I'd like to preface and say that, I'm really not a nursing home administrator expert. This work was funded by a small grant through the College of Social Science. To study COVID. And at the time, I was just really kind of taken by what was happening in the nursing homes. And I thought this might be a good time to at least investigate, a little bit and see a little bit more, what patients were experiencing, healthcare providers. And so we conducted this study, and I hope you find it interesting. So my colleagues are Amanda Cruz, Kwang Zhang, who just graduated, both with their PhDs, Rachel Portelli, Erika Ligman-Zielinski, and Nicole Deer. All right, so in January 20th, 2020, the CDC reported the first US case of the novel severe acute respiratory syndrome, SARS-CoV-2, later referred to then as COVID-19 because it was identified then in 2019 in a 35-year-old woman. About a month later, on February 28th, 2020, the first COVID-19 death occurred in the United States, and it was in a 50-year-old man, also a patient in a nursing home in King County, Seattle, Washington. At that time, there were 60 other COVID-19 cases had been identified in the country, and about 85,000 detected in 57 countries worldwide, with about 2,900 deaths. And then moving forward here, as of February 2022, there have been over 78 million COVID-19 cases in the country, with almost 100,000 deaths, 891,252 deaths, with a case fatality rate of about 11.9 per thousand. And of these, about 15% of deaths occurred in nursing homes. And I didn't have this written, but I quickly looked it up, and about a third of those deaths in nursing homes occurred in the first 10 weeks of the epidemic, or the pandemic. So the purpose of this study then is to improve our understanding of COVID-19 cases in nursing homes and facility and neighborhood level risk factors for premature death. So we studied the diffusion of COVID-19 in two ways. The first was to construct epidemic curves overall and by HHS region. For weeks 1, which began on May 31st, 2020, through week 90, which was just most recently, February 13th, 2022. So the epidemic curves cover the whole time span that COVID has been with us. And then we also looked at the spatial trends of COVID by Health and Human Service regions from week 0. And I'll explain week 0 is May 24th to week 9, which is July 26, 2020. So week 0 is really looking at retrospective cases from when surveillance began. Surveillance actually began then on May 24th, and the very first week of surveillance was May 24th to May 31st. But cases, as surveillance happens, cases retrospectively appear. So week 0 is really from January 1st up through May 24th. And then after presenting, the studies of diffusion of COVID-19, we then looked at regional explanations for the early onset of the diffusion in weeks 0 through 9. So those of you who, everyone's probably familiar with the HHS regions, but because we'll focus on them so closely, I did want to point them out where we have region 1 up in the Northeast. Region 2 is New York and New Jersey. Region 3 is, you can see those states, including Washington, D.C., over on the East Coast. Moving south into region 4, back up north into region 5, where Michigan is in region 5. And then back south into region 6, where we have Texas and the surrounding states, region 7 in the middle of the country, up into region 8 in the northwest, region 9 in the southwest, and region 10 up in the far northwest. So the data that was used to create the epidemic curves was the COVID-19 data tracker on confirmed COVID-19 weekly cases and death counts in nursing homes. And the more in-depth nursing home surveillance data was obtained from the Centers for Medicare and Medicaid Services. And again, this was for the first 10 weeks, or actually the first 9 weeks, including that week 0. And that data was cleaned to remove unvalidated cases, and new variables were constructed for the nursing homes, including bed capacity, bed level, whether the nursing home was a VA facility or not, and then joining the state and the HHS region to those data. And then these data also contained a latitude and longitude location of the nursing home. So we displayed that in ArcGIS and then spatially joined the CDC's social vulnerability indices to assess the quality of the neighborhood in which the nursing home was located. The methods that were used to construct the epidemic curves, again, we used the confirmed COVID-19 weekly case counts, and then the deaths were overlaid then as case fatality rates using 3-week running averages. And the spatial trends were created using the point locations of the nursing homes, and then the confirmed COVID-19 weekly cases were spatially smoothed to locate concentrations of nursing homes with high case counts. And then a bivariate spatial autocorrelation was used to identify nursing homes with high case counts and high deaths in red, low case counts and high deaths in orange, and high case counts and low deaths in blue for surveillance week 0 through 9. And the 3 types of diffusion that we'll look for are contagious or expansion diffusion, meaning they kind of start in a location and kind of spread out. Relocation diffusion, where the source would be in one location and then kind of relocate farther away. This is less common. And hierarchical diffusion, where the source would start, say, in an urban area and diffuse out to smaller towns and into the rural areas. And then zero inflated negative binomial models were estimated within HHS regions to evaluate facility and area level social vulnerability risks for COVID-19 deaths. And in those analyses, we looked at week 0 and then aggregated weeks 1, 2, and 3, weeks 4, 5, and 6, and weeks 7, 8, 9, in order to have a robust data set to conduct these analyses. Honestly, I can't see anyone. So if you do have a question, please feel free to speak out, okay? Because I can hear you, but I just can't see right now. All right. So if we look at this first epidemic curve, and this is across all neighborhoods in the country, or all nursing homes in the country. So we can see that we really have kind of 3 epidemic peaks. The first one's around week 5, 7, 9, 11. The second peak occurs around week 21 to 37. Toward the end of the second peak are when vaccines were introduced around week 32. And again, these are close times in which vaccines were implemented around week 32. I don't want to say exactly on week 32, but around that time they were introduced. And then if we look at the 3 variants that we've been working with, the Alpha variant appeared around week 48. The Delta variant appeared around week 62, and the Omicron variant then around week 82. So if we look at the case data, and we can see these epidemic peaks, but also real troughs. Look at that large trough in between week 39 and 61. But then if we overlay the case fatality rates on top of that, we can see that very early, the first 3-4 weeks in the epidemic, we had higher case fatality. And then case fatality kind of leveled out a little bit. And then we had a delayed, kind of a lagged reaction from that second peak of cases where we see a higher case fatality after that. And then it starts to drop off. And as we get longer into the pandemic, and especially I think it's very interesting to note that with the Delta and especially the Omicron variant, after it was introduced, we have exceptionally high case counts, right? But our case fatality rates have dropped substantially. So this is the overall picture of nursing home cases and case fatality rates for the country. And then if we break it down by HHS region, and these look like a lot of graphs, but there are 10 of them. But I think by looking at each region, we can begin to better understand the diffusion. And we can see here up in region 1, up in the Northeast, there were very few cases to begin with, in part because it's less populated than other regions, but very, very high case fatality, especially in the very beginning. And then we impose the locations then of when vaccine in the different variants were introduced. So we again see this lagged case fatality after that. Here, it would be like a second peak in region 1. In region 2, moving down then into New York and New Jersey, we also see very high case fatality early in the pandemic. And then we also see this lag of case fatality after the second peak. Moving down then into region 3, we see a little bit lower case fatality in the beginning, but those peaks of case fatality continue after that second peak of cases. And then region 4, here we're moving south, and we can see that the pandemic, actually quite a few cases begin to occur. Then we almost have 4 peaks or another peak early on in the pandemic in region 4 as it kind of move quickly south. And we'll see that on the maps that as regions 1, 2, and 3 were experiencing COVID very, very high, it wasn't that much longer that we then see a rise in region 4, as well as a rise in region 6, if we look over on the other graph on the right, upper right. But then region 5 is where we live. We also saw some relatively high COVID case fatality early in the pandemic. And I wanted to point out in region 6 that really, really high peak is a data anomaly for the case fatality rate. That was a data anomaly. It was surveillance data. Sometimes we see these anomalies, and we had quite a few more deaths than we did cases in that particular data set. So I didn't remove it. We'll just present it.
So can I ask a question? I think you might have covered it earlier, but I maybe got confused.
Sure.
So because deaths lag, hospitalizations lag cases, and deaths lag hospitalizations. So as you're looking at the case fatality rates, I'm guessing you're doing some kind of average of the cases, not just the cases at that time, right? So I was trying to figure out the denominator kind of for it.
Oh, I'm so sorry. I should have mentioned that.
Okay, so I didn't miss it. I just want to make sure.
No, I'm so glad. The case fatality rates are actually 3-week running averages.
Thank you. Yeah, I guess they had to be something like that.
Yeah, thank you.
Okay, thanks.
So, yeah, so then we see region 7, which is kind of right in the middle of the country. And then looking over at region 8, which is going up into the northwest. And those 3-week running averages that had less than 20 deaths were actually removed then from the graph to so that we didn't present any instability in those rates during that time. So there's a gap in that time period. And then if we look at region 9, moving down into the southwest, we can see that. Is my internet okay? All right. Are we okay? Hello?
I thought it was on my end, but I guess it might be on your end if you were also noticing it.
Okay.
It's okay now. But yeah,
All right.
we had a little stall for a moment.
Oh, okay. I always worry about that in my office here. It becomes unstable once in a while. So region 9 then, much of region 9 was driven early on by Los Angeles. And then if we look over at region 10 up in the north, the far northwest, the case numbers are quite low, but again, case fatality was a little bit high during that lag period after that second peak. So this gives us a little bit of an idea, the beginning of understanding the diffusion of both cases and case fatality rates. And then if we look within those regions and look a little bit more carefully where we saw the high case fatality rates in region 1, 2, and 5, we can see that they do have the overall highest case fatality rates. So if we look at region 1, that was primarily driven by Massachusetts and followed by Connecticut, where their case fatality over the first 9 weeks or 10 weeks, including week 0, was 32.58 per actually 100 residents. And then region 2, New York and New Jersey, their case fatality was 34.13. And then in region 5, the case fatality was 31.35. And I wanted to point out that given these nursing home data, Michigan actually had the highest case fatality of 40.93 during this particular time period. So each region had different states that were somewhat driving the pandemic in that region during those first 10 weeks. The overall case fatality was 26.62. And I think it's really important to note that by the end of the 9th week of surveillance, the 10th week, including week 0, there were 46,173 deaths in nursing homes. So again, about a third of the total nursing home deaths occurred during this first 10 weeks. So if we start to look at the maps, then we can see here the regions aren't overlaid. We put the map of regions down in the corner there in order to best display the data. But if we look at the smoothed area, those are COVID cases in nursing homes that were spatially smooth. So we're looking at the density per square mile of COVID cases in nursing homes. And the dots then, the red dots again are nursing homes that had high cases and high deaths. So high COVID cases and high deaths. The orange are nursing homes that had low COVID cases, but high deaths. So that's very important, few cases, but high deaths. And the blue are high cases, high numbers of cases, but fewer deaths and low deaths. So when we look at this very beginning, this week 0, retrospectively looking back through January up to May 24th, we can see that the nursing homes up in the Northeast in region 1, 2, and 3, particularly 3 up in the far Northeast, had very high COVID, nursing homes had very high COVID and high COVID deaths. Looking over into the Detroit area, most of these are urban areas, as we can see. The Detroit metropolitan area, Chicago, looking down then into Atlanta, New Orleans, and then if we look over onto into Los Angeles. But much of the pandemic at this time was situated then up in the Northeast. If we go then to week 1, 1 week later, we can see that many nursing homes in the Northeast, death rates are beginning to drop. We start to see a little bit more contagious diffusion by expansion of the gray areas in COVID cases. And then we begin to see some expansion in terms of high cases and high deaths, as well in many of the urban areas, as well as some hierarchical diffusion. It appears to be where we see more areas in the South, not necessarily all in urban areas, but outside of urban areas where there's lower case counts, but still high deaths. We look at week 3, we see a little bit more of the same kind of expansion. And we start to see that up in the Northeast, those nursing homes, even though they still have high cases, their death rates are dropping considerably. But we are seeing more increases in deaths still in the urban areas with a little bit more concentration in the South. By week 3, we see quite a bit more expansion diffusion in terms of the COVID cases. Again, more expansion diffusion, and then more expansion and kind of hierarchical diffusion in the South. And I think the orange dots are really something to look at. As I said, these are nursing homes then with low case counts, but high deaths. And they start to kind of trickle around all over in the South. So again, kind of this pretty much the same story. But here we are in week 6 now. We can see in the Northeast, many of those hospitals, but not all, but many up in region 1 are beginning, then the death rates are dropping. And then we see other areas in the South where there are also higher nursing homes with higher case counts and lower deaths. But it's still the nursing homes with high case counts and high deaths and low case counts and high deaths still are really scattered. Particularly, we see more now in Indiana, down into Kentucky, Tennessee, kind of a trickle down then also into the South through the middle of the country. By week 7, we're seeing a lot more blue up in the Northeast, which is really good. But now we're seeing more nursing homes with low case counts and high deaths moving across the South from the Southeast into the South Central area of region 6 into Texas, into the urban areas of Texas. And now at this point in week 8, we see a lot more nursing homes in the South with both high cases and high deaths. In the North, in the Midwest, regions 1, 2, 3, and 5 are really seem to be getting bringing down their death rates quite substantially. But those nursing homes in the South are still experiencing their high death rates. And we're seeing some movement now into the West. In week 9, looking really good for the Northeast and the Midwest, Michigan and Chicago. But the South is still experiencing very high COVID deaths, and a little bit more up in Washington State as well. So that is a presentation, a descriptive presentation really of the diffusion of COVID cases and deaths in nursing homes across the country. Kind of a visual descriptive presentation of that. Now to really begin to try to understand that diffusion, what we did was then to implement the zero inflated negative binomial models. And this looks like a lot of data, and it is a lot of data, and it was timely. But picking out those regions during week 0, if we go back and look at the map on week 0, these were the regions that were most affected at that time. So better understanding the risk factors within those regions during that first time period is what we set out to do here. So if we look at the confirmed COVID cases, I don't have a pointer, but if you read down on the left-hand side where it says confirmed COVID-19, and we look across, the magnitude of infected patients within the nursing homes really had an impact, which we would expect on COVID deaths during that time across all of these regions. So having confirmed COVID patients in the nursing home at the time really had an impact on mortality. And then in terms of hospital admission or patient admissions, generally from hospitals, but we don't really know where the admissions came from. But we see in region 2, that was a significant risk factor for mortality, as well as in region 5 during this initial time period. We can also see that staff confirmed with COVID-19 was significant for mortality in regions 1, 2, 5, and 9. It looked as though bed level 3, which is kind of a medium-sized nursing home, was significant for mortality in region 2 and 3. In region 5, it was primarily the larger hospitals. And social vulnerability really wasn't a risk factor during this early time period. It was primarily facility level risks that were contributing to mortality. Except in region 9, we see that mortality was primarily occurring in areas that were social vulnerability theme 4. I haven't explained those. I will as we go along and look at those risk factors. But theme 4 is areas with substandard housing as well as low automobile use. And many times we'll attribute this area to more inner city urban areas. My sense that even though urban was mildly significant, but my sense is that this is perhaps more in the Los Angeles area. But again, we'd have to, this is purely kind of relating the findings. Okay, so if we move then into the second time period, aggregating weeks 1, 2, and 3 from May 24th to June 14th, and the regions 1, 2, 3, 4, and 5 were pretty heavily concentrated in terms of high COVID and high case fatality. So these regions were then studied more in depth. So we can see that confirmed COVID cases isn't as important as a risk factor in region 1. Staff confirmed was still. In region 2, it was. Having other patients with COVID was still important, as it was in region 4. Region 4 now moving into the south, the southeast. So as diffusion occurred down into the southeast, region 4 is beginning to appear similarly to in terms of its risk factors. And having COVID patients in nursing homes then also contributed to high deaths, as well as persisting in region 5. So we see here in terms of COVID admissions into the nursing homes, it was region 5 that was still experiencing that as a risk factor for mortality. But if we look across, staff confirmed with COVID-19 was a risk factor for mortality across all of these regions. So staff shortages started to appear in region 5. And then we see a real expansion now of bed level 3 and 4, more of the larger nursing homes. And we're starting now to see a little bit more in terms of social vulnerability and where the neighborhoods or where the nursing homes are located. So in region 3, which is in the far east, remember, poor neighborhoods. So social vulnerability 3 and 2 has to do, 2 has to do with more older neighborhoods, more dependent residents. And that was a risk factor for mortality. So nursing homes in those types of neighborhoods in region 3 then were at greater risk of mortality. In region 4, we can see that in the south and the southeast, living in a high minority or low English speaking neighborhood, the nursing home in those neighborhoods were at greater risk then of COVID mortality. So this is very, very important because up until this point, facility level risk factors kind of dominated, but as we move in time, we're starting to see more neighborhood level risk factors. And then in weeks 4, 5, and 6, from June 14th to July 5th, again, regions dropping out region 1 because that was becoming less of a concern in terms of COVID mortality, and then adding region 6 down in the south of Texas and surrounding states. So here we see that confirmed cases are highly significant in having confirmed COVID cases in the nursing home was highly significant in region 2, region 4, region 5. Admissions were highest in region 4 and region 6. So we'll talk a little bit about that. And then if we look at staff confirmed with COVID, we still see that as a significant risk factor, but not anymore in region 2 or region 4, but still in region 3, 5, and 6. But we see now more nursing shortages, or staff shortages, I should say, including staff with nurses. We see that as an emerging kind of risk factor for COVID deaths during this week 4, 5, and 6, both in regions 2, 4, and 5. So the bed levels are about the same, mid and larger size bed levels. We continue to see in region 4 that the nursing homes in high minority and low English speaking neighborhoods are at greatest risk. In Region 5, we start to see this also. So in Region 5, in weeks 4, 5, and 6, we start to see that those nursing homes in high minority and low English speaking neighborhoods were at greatest risk of COVID mortality then. And then in Region 6, we see the urban area really emerges then, nursing homes in urban areas. And during this last time period in weeks 7, 8, 9, again, looking at regions 2, 3, 4, 5, and 6, we can see that having confirmed COVID patients in nursing homes was significant for mortality in regions 4 and 6. So again, in the South, but not in the North or the Midwest. Admissions into nursing homes were a risk factor for mortality in regions 3 and 4. Staff with COVID really starting to drop off, but still persistent in regions 4 and 6, as well as nursing shortages in regions 4 and 6. And kind of glossing over the the bed levels were still significant. Here we begin to see that in Region 3, the veterans' homes in Region 3 were more significant now for mortality. That was the first we saw veterans' homes. There was a lot of discussion, I remember, during the time about the veterans' homes. So we were a little surprised we didn't see that earlier, but it did appear in Region 3 during this week 7, 8, 9. And then looking at the different the area level risk factors, we can see in Region 2 that, again, older neighborhoods with high dependency was important in Region 2. And lower, there was lower mortality in those neighborhoods that were neighborhoods with lower quality housing and low automobile usage. So my sense is here is that that those nursing homes, that there was kind of a movement then out of neighborhoods with poor quality housing and low automobile usage, perhaps then kind of moving then into poor neighborhoods or older neighborhoods. So there's some shifting going on. Of course, this can always be studied more. It's kind of a beginning here, but we start to see some shifting. In Region 4 too, out of those areas, but not necessarily, we don't know into what other areas in terms of the social vulnerability in theme 4, which is again, lower income housing and low automobile usage. And then in Region 6, moving out of the urban clusters. So I'm not explaining the bottom part of the graphs or the tables in terms of what is explaining the zeros, trying to, for the presentation, focus on those risk factors in nursing homes during these time periods. All right, so some discussion here. If we look back over the epidemic curves, we really had two main epidemic peaks with elevated, although we saw smaller peaks in different regions, but primarily two epidemic peaks with elevated case fatality rates early in the pandemic in regions 1, 2, and 5, and then lagged high case fatality following the first peak across all regions. The Alpha and Delta variants did not contribute to real rises in cases, but the Omicron variant did lead to a second epidemic peak. In the first 10 weeks, COVID-19 case fatality rates were highest in Region 1, 2, and 5, with the highest case fatality in Michigan. And then in terms of disease diffusion, COVID-19 cases and deaths were observed in week 0 across the country. with the greatest concentration of high cases and high deaths in region 1, 2, and 3, as well as Chicago and Detroit, indicating some contagious diffusion subsiding by week 4. In weeks 1, 2, and 3, more nursing homes, and this is where we really saw the movement into the south, where there were quite a few nursing homes with low case counts but high deaths. Whether we call this relocation diffusion, it's hard to say, but we did see a movement kind of from the Northeast in the Midwest to the South. And then some expansion, of course, of nursing homes with high cases and high deaths thereafter. And we really did see then, once the urban areas, particularly in the South, were impacted, there was hierarchical diffusion out of the urban areas into the surrounding areas, especially across the South. So just summarizing the findings then, during week 0, significant risk for COVID deaths were confirmed COVID-19 cases across all regions, admissions of COVID patients into nursing homes, region 1, 2, and 5, and staff confirmed with COVID-19 significant risk factors in regions 1, 2, 5, and 9. Mid-sized nursing homes were most affected, large nursing homes in region 5, and deaths were significantly high in urban areas in region 9. Now, interestingly, barriers to such care as laboratory testing, whether there was a ventilator unit, and nursing shortages were not significant risk factors for nursing home deaths. So those were variables that were also in the model, but they weren't significant in any of the models. So we didn't add those to the table, but I want to point that out here. In this second time period, significant risk for COVID deaths were staff confirmed with COVID-19 across all the regions, 1, 2, 3, 4, and 5. I shouldn't say all the regions, but the regions that had the highest death rates. Admissions of COVID patients into nursing home and staff shortages emerged in region 5. More large-sized nursing homes were affected, and nursing homes in vulnerable neighborhoods with high dependency, high minority, and low English speaking were most affected. And again, barriers to laboratory testing and ventilatory units were not significant for nursing home deaths. Third time period, again, significant risk for COVID deaths were admissions of COVID-19 patients in regions 4 and 6, and staff confirmed in regions 19, or in regions 3, 5, and 6. Staff shortages emerged as a risk factor in regions 1, 4, and continued in 5. Again, mid and large-sized nursing homes most affected, and we see more nursing homes in vulnerable neighborhoods in region 4 and region 5 in high minority, low English speaking, and also in urban areas of region 6, especially in Texas, Dallas, Houston, Austin, as well as New Orleans, Louisiana. And laboratory testing and not having a ventilatory unit were not significant risk factors for nursing home deaths. And finally, significant risk factors during this last time period were still admissions into nursing homes in regions 3 and 4, and staff confirmed and staff shortages in regions 4 and 6. Region 3 had significant deaths in their VA nursing homes. Vulnerability moved out of minority neighborhoods in region 2, outside of core areas in regions 3 and 4, and outside of urban clusters in region 6. Laboratory testing and not having a ventilatory unit were not significant risk factors. And most nursing homes in the Northeast and Midwest that had high cases and high deaths now had high cases but low deaths, while many nursing homes in the Southeast, the South Central, had high cases and high deaths, and most commonly low cases and high deaths. So summarizing everything, I know it's a lot, but admission of COVID patients with COVID-19 into nursing homes was a significant risk factor for mortality, occurring in weeks 1, 2, and 3 in the Northeast and Midwest. Those lessons were not passed on to the South. My sense is that in one of the reasons for studying the HHS regions was to think about that level of administration that we really didn't hear much about. We hear kind of at the federal level and we hear about the state level. But at least for me in our group, we really didn't hear a lot about what was happening at our regional level. So one of the lessons learned, I think that we could perhaps do a little bit better of a job communicating across our regions. And perhaps we could have avoided some of the mortality. Perhaps everything was moving very, very fast. But as soon as we knew that admitting patients into nursing homes with COVID up in the Northeast and Midwest was a risk factor for mortality, we perhaps could have passed that lesson on to the South. Again, and it's easy to say when you're working in the middle of it all, it's very hard, but it could be a lesson learned. Staff confirmed with COVID was a significant risk factor, but dropped off. At the same time it dropped off, staff shortages started to emerge. So perhaps, looking back, again, we have the luxury of being able to look back now, thinking about staff and making sure, well, there's a lot of discussion about the conditions that the staff were working in at the time. So I give them all the credit that they deserve, but it's just something in terms of planning ahead, what we might be able to do better in terms of screening staff, as well as providing or planning ahead that we're going to probably need more staff. Mid-sized nursing. Yeah.
I ask about the staff shortage ones. So the staff having COVID was a risk factor, but staff shortages were not a risk factor for the COVID deaths, or they were. Couldn't.
Oh, they came. Yeah, they came a little bit later. So around that third time period is when we started seeing staff shortages as a risk factor.
Okay, so both of them are a risk factor. So it wasn't really like you could have. So the solution to this is not work anyway, because we don't want shortages. The solution is screen and then get substitute staffing, like the National Guard and some of the things people have been doing.
Yes.
Okay.
And have that prepared. Yes. Yep. So there really was a temporal component here in terms
you couldn't see the one because the other hadn't happened. Yep, I get that.
Yes.
Thank you.
Sure. And then mid-sized nursing homes were most affected in the beginning, followed by large nursing homes, kind of generally. And nursing homes in vulnerable areas, in terms of neighborhood or area level risk factors, came a little bit later, emerged, and they weren't there present in that week 0, but they started to emerge in week 1, 2, and 3. So perhaps, again, it seems obvious, but focusing on those nursing homes in vulnerable areas to begin with, targeting those nursing homes first, and then continue to protect our veterans' homes, while barriers to laboratory testing and ventilatory units were not significant risk factors for nursing home deaths. That's something that we always will need to continue to look at moving forward. And this study was conducted pre-vaccine, so further studies evaluating vaccine response are warranted. So some references, acknowledgements. Again, Amanda and Kwong just graduated. Nicole Dear, she is a PhD student in our department right now. And Rachel and Arika are geography faculty in the department. And I'd like to also acknowledge then the healthcare workers helping the elderly in nursing homes. And a couple of pictures here for you. So that's all I have.